It's Melissa Sweet, public health journalist, reporting for Croaky News from the National Rural Health Conference, which has just wrapped up in Cairns. I'm really delighted we have Dr. John Hall here to speak with us about a very interesting and important proposal he's been working on for rural health. But first of all, John, can you just introduce yourself to our viewers?
For sure, thanks Melissa. Yeah, look, my name's John Hall. I'm a rural GP from Oakey in Queensland. I'm a GP obstetrician and rural generalist, and I'm also Vice President of the Rural Doctors Association of Australia. And we've been working on some health policy around the first response or emergency response at the scene and how we could better coordinate that.
Why do we need to do that? I mean, as a layperson, I would just assume that's all been sorted.
Yeah, look, over the years we've had a lot of our members with the Rural Doctors Association come to us with concerns about not being informed of major disasters happening on their doorstep and not being brought into the mix when the response to disasters is centrally coordinated by emergency services. So one of the key events that really brought this to light was the Cairns train crash in Victoria in 2007, where there was 12 fatalities, and the local doctors in the hospital, there was 2 guys there that had advanced skills in anaesthetics that would have been very helpful there in responding to that, in potentially managing some of the airways. And they were actually, not only were they not informed, they weren't even they weren't allowed into the scene, so they were blocked from being involved even when they did find out about it. There was a coroner's report around that clearly articulated the fact that they should have engaged the local team. What we're looking at in this new body of work is how can we structure this? How can we make it easier for emergency services to access the local guys? And we're using a model that's already existing in South Australia called the Rural Emergency Responders Network, or RERN, and they've got a great system whereby they have an opt-in system for rural doctors who can put their hand up and say, look, I want to be one of these guys that will respond pre-hospitally or in disasters. So they might go to a multi-vehicle car accident or rollovers. They go and assist and help at the scene with the ambos and the fireys and the police that often attend these significant events and other disasters. So it's an opt-in system where they choose to do that. But it also comes with a lot of support. So they get extra training, so they get trained in the pre-hospital space. They get to work alongside their emergency service colleagues with orientation and training as well. They get kitted up with the right gear, so they get an emergency bag which is stocked and funded by the state government. And they're also given pages, so they're actually directly linked into the 000 response. So these guys are notified and they've got set call-out criteria, so they're not just rung all the time for little things. They would only be called when it was identified by the local officers or by the comms triage officers that it was going to be a multi-casualty event, or that the ambulance officers there might need an extra pair of hands or more support.
Could you explain? It just doesn't seem to make sense. Why would emergency services exclude GPs or local, medicos from being involved in emergency response?
Look, I've drilled down into this, and we've had a lot of chats with our friends and colleagues who do the coordination of emergencies, and I think it's come from bad experiences that they've had where the wrong type of doctor has actually tried to assist in emergencies, and it's been difficult or it hasn't been a value add. And I think what's happened is that's just flowed into, I guess, not considering that in rural areas, your GPs have specific training in critical care and emergency, which you mightn't find in other environments. So I also think it's because it's the fact that they're an unknown quantity. And this is what's so good about RERN, is that it's actually giving the emergency services the confidence in knowing that if they ring Dr. X, he's got the right skills, he's credentialed, he's got the right equipment, he's a known quantity, he or she is a known quantity that will be ready to assist them. So I think it's because doctors are such a broad bunch of people, and there are a lot of doctors that wouldn't be evaluated in an emergency based on the skill sets that they have on a day-to-day basis. So I think that's where it's come from, and hopefully we can mirror the South Australian system and get something like this rolled out nationally.
So what's it going to take to make that happen?
Look, we've been working on this. I've been working on this with a doctor by the name of Tim Leuenberg, who's in South Australia. He's at Kangaroo Island. He and I co-authored a paper that was published in the Australian Journal of Emergency Medicine. So we've surveyed our doctors. We've looked at who's doing this already. We've looked at what different doctors across Australia think about this, and we've done a lot of work that basically says it's happening anyway. Our doctors are keen for there to be some structure around this. What we really haven't done yet is start a deeper conversation with our emergency services colleagues. So what we're actively trying to do now is tee up meetings on a state-by-state basis with the emergency services. So we're trying to get our members around Australia to get involved with those statewide bodies that are coordinating and arranging disasters at a strategic level, and hopefully look at getting these models built state by state. Because emergency services and ambulance services are generally a state jurisdiction, it's hard for us to roll something out nationally, but what we're doing through the Office of the Rural Doctors Association of Australia is helping to facilitate the individual states in starting to get this going. So, but it's going to be difficult, and it's going to, we don't have a lot of resources at RDAA, but what we are really keen is for our emergency colleagues and medical administrators to join the conversation and support us through this. We don't think it's going to be expensive. Most of the structures in place, it wouldn't actually take a lot of money and time to make this happen. And at the end of the day, it's about rural communities and making sure that people that live in rural areas have got the best access to emergency care that they can have. And we think this is a yawning gap because it's really disadvantaging rural people that have major emergencies, because there's often significant delays in getting the retrieval team there, or even getting the ambulance to some of these towns. So, there needs to be a gap in the middle there where local healthcare workers that are already on the ground can be mobilised and help in that space.
What are some of the types of incidents we're talking about? You've mentioned a train crash, and you told me this morning about a bus crash, I think, but what are some of the other types of incidents where this might be useful?
Look, it would be useful in, I've had a situation in my town where the ambulance was out of town on another job, and I got called to my private practice via the receptionist, and it was comms asking for a doctor to go to the local school because a child had arrested and a child needed resuscitating. That's fraught with danger because they had no idea which doctors were there that day. There was only one doctor, that was myself, that would have had the skills to do that paediatric resus. And so, you can imagine with a RERN type system, if I'd had a pager, they would have been able to really confidently know that they were going to get the right doctor to the right place at the right time, which under the current system, it's just fraught with so many potential flaws that could have led to that kid not getting attended to. It might have been another 40 minutes before the ambulance got to her. So, look, there's lots of situations like that in rural areas where the emergency services aren't available or out of town. And the other thing is that flight retrieval often can't come in. So if it's inclement weather, if there's technical problems, if the flight assets are deployed elsewhere. I've been in many situations in rural hospitals, scary situations, where you really need intensive care retrieval services there and they can't come, and it's out of their control. It's not anyone's fault, but there are real situations where retrieval services can't come, and I think it's important that the doctors on the ground that can provide these skills are actually linked in through comms, through the 000 system, so that there's direct access to them, not just leaning on old systems, which is phone calls to hospitals or phone calls to practices, which is fraught with danger.
So if anyone hearing about this from you would like to support this work, how can they do that?
Oh, look, the best thing to do is to get in touch with the Rural Doctors Association of Australia. We've got an office in Canberra. We're all on Twitter, so you can tweet me, send us direct messages. We'd be very keen to get people involved in the conversation and help us to mobilise this Australia-wide.
Fantastic. And what's your Twitter handle?
It's @JHRural.
Brilliant. Thank you very much. It'll just take me a second here to